there. Thank you once again for joining me as we continue our discussions around the COVID-19 pandemic. I'm Dr. Mahendra Carpen. I'm the head of medical services and cardiology at the Georgetown Public Hospital Corporation. As we continue this conversation, please remember that if you have questions of your own, you can send a WhatsApp message to 620-6275, or you may send an email to docandcovid@gmail.com. For the rest of this discussion, I will take my mask off so that we can continue to have this conversation without being impeded by the mask. There's no one here within 6 feet of me, so I am not exposing anyone, and I myself am not being exposed. So I wanted to look at some locally relevant information and do some comparisons as we examine data from around the world. We generally think often that we are not as good as elsewhere, and things in Guyana are worse than elsewhere. So I wanted to put that in numbers, because as you've all heard, the numbers don't lie. So let us look at what our experiences are. And I can look and talk about what happens at the Georgetown Public Hospital Corporation, because that is the final referral center for all sick COVID-19 patients, and generally it is the referral center for the country for all persons who are sick enough and cannot be managed adequately in the regional hospitals. So the experience at Georgetown Public Hospital in the COVID ICU has been revealing. We know that when this pandemic touched down in Guyana, we were not prepared from an infrastructure point of view, human resource, training, testing, several fronts. We needed to improve to be better prepared to deal with it. In fact, the rest of the world, the majority of places were not prepared. This is brand new to the world, and so everyone started a learning process. So we had to create an ICU that specifically looked at COVID positive patients at the Georgetown Public Hospital, to create all the protocols, all the admission criteria, the handling, everything had to be written down and discussed, and we had to make sure that all of this is done in conformity with existing guidelines. So to date, and this presentation was prepared about 2 days ago, we had 245 admissions to the COVID ICU at the Georgetown Public Hospital. That number has since moved to 250 in the 2 days since I have prepared this presentation. We have had a total of 101 deaths in the COVID ICU, which is about 40% of all admissions. 61 would have been admitted to the COVID ICU. 20 persons died in the emergency room, 17 died in the transition ward, and 4 died in the open ward. Now the transition ward is an area that we keep persons who have suspicion, or we are suspecting that they have COVID-19 based on their symptoms, but we are awaiting results until we can confirm that they have positive or negative, and then we can have them moved to the appropriate place for continuing medical treatment. Remember, in the early days we had delays in receiving results up to 7 days, and that resulted in a lot of patients backing up and having to stay in the transition areas. If you look again at the number of deaths in the emergency room, that's 20 out of 101. So that's 20%. What does that mean? Is that mainly people wait until they are so sick and they come to the emergency room, because people don't usually wait in the emergency room for more than a day or two. So by the time you get to the emergency room, those persons were so sick that they didn't have a chance to be stabilized enough to then move on to the COVID ICU. And that is one of the things we have to pay close attention to, that persons having symptoms should seek medical attention before they become so severely ill that they would have not gotten or not given themselves a fighting chance before they get to hospital. At the time of preparing this presentation, there were 7 persons in the COVID ICU. As of today, there are 8. There's 1 additional, but at this time there were 2 intubated persons, that they were on ventilators. 1 was receiving airway support by continuous positive airway pressure, something we call CPAP, and 4 of those persons there were considered to be critical. There were 22 in transition ward, including 4 children, and we looked at the maternity positive patients as a separate group, and there were 7 of those at the time of preparation. So we see that in our COVID ICU, we have a mortality of about 40% of all persons who were admitted. How does that really compare to elsewhere? If we look at data coming out from the UK, in the early days of this infection, way back in April, we saw that of 690, almost 700 persons who were admitted to their critical care unit, there was more than a 50% death rate. Only 49% that were discharged or were alive at the time, and they had 50% of patients would have died. We have learned a lot from April to now, which is November, and so our approach, especially to ventilated patients, is different now than it was in April. And this is the unique dynamic thing about the pandemic. Every day there is new research, there is new information, new techniques that are being discussed and are being revealed that help us to better manage these patients. The next thing that we look at is what is the experience in somewhere else. And if we look at what happened in Scotland, in their ICU, their critical care ICU that looked at the COVID-19 patients, there was a 44% of patients who were discharged. So that means there was an increase, more than half of those persons, or 32% actually had died, and there was still about 20% of persons in ICU. We don't know what happened to those persons after. The mortality rate is worse, or the death rate is worse for persons who require ventilation or who require being put on a ventilator for airway support. And that fact is worse as you get older. So in the 18 to 59 age group, those persons who required ventilation because of COVID-19 disease, 28% of those persons would have died, versus those above the age of 70 to 79, 63% would have died if they needed ventilation. And if you're older than 80 years old, almost 3/4, 72% of those persons died when put on a ventilator. That is a significant mortality rate in the older persons when they go on the ventilator. So across continents, does this fact really change? The answer is no. The ICU mortality did not differ significantly across continents, despite evidence of variations in admission criteria and the treatment that were given. So the death rate, the mortality rate was the same in Europe as it is in South Africa, as it was in Asia, and so it didn't matter what the admission criteria was. or what the treatment was that was administered to these patients. What about persons with pre-existing conditions? We see the death rate significantly higher among those who have heart disease, diabetes, chronic respiratory disease, high blood pressure, cancer, and those persons with comorbid or pre-existing conditions, when compared to those without comorbid or pre-existing condition, for example, in heart disease, it's almost 10 times more. If we look at the overall hospitalizations, the hospitalization was 6 times higher, and deaths 12 times higher for COVID-19 with underlying conditions than for those without underlying conditions. And the most common reason, or the most common comorbid condition that was associated with increased mortality, was cardiovascular disease, followed by diabetes, followed by lung disease. In Guyana, we have seen chronic kidney disease playing an important role here as a comorbid condition, cancers and other infectious disease that cause decreased immunity in these patients. There's other main recognizable risk factors in comorbidities is extra weight. And we see that persons, based on their BMI calculation, those within the normal BMI calculation had a much lower death rate after developing severe COVID than those who had a diagnosis of obesity. Obesity is defined as having a BMI of greater than 35. So that is also an important comorbid condition that can lead to increasing mortality rates in patients admitted with COVID-19. In terms of the common conditions or comorbid conditions that persons have who are admitted, we see that the commonest comorbid condition that is present in all admitted patients with COVID-19 is hypertension. Then there is obesity. Hypertension, more than 50% of the admitted persons with COVID-19 have hypertension. The same is true for obesity. More than 50% of admitted COVID patients had an underlying comorbid condition of obesity. Cardiovascular disease represented about 1/3 of all admitted patients with comorbid conditions. Chronic lung disease is about 20%. Renal disease about 14-15%, and asthma about 13%. So there is significantly increased number of admissions in persons who have underlying comorbid condition. And so that is important to note, because if these conditions are not properly controlled, it can lead to adverse or worsened outcome in these group of patients. Because these persons with underlying conditions or underlying comorbid conditions are much more likely to die than those without comorbid conditions. So for example, those without comorbid conditions are hospitalized at a rate of 7.6% for all infections of COVID-19, compared to those with underlying comorbid conditions that we talked about, like heart disease, diabetes, obesity, etc. Those with comorbid conditions represent 45%, almost 50% of the hospitalization. ICU admissions for without comorbid condition was just 1.5%, but ICU admission for those with comorbid conditions was 8.5%. And death rate again, is significantly different. Those without comorbid condition, the death rate is 1.6%, but those with comorbid conditions, the death rate is about 20%. So I hope this sheds some light on some of the statistics that we have accumulated locally, and to give us a comparison to see where we are on the international scale of things in terms of our survival, death rate, etc. Remember, if you have any questions regarding the COVID-19 pandemic, you may send it to WhatsApp at 620-6275 or send an email to docandcovid@gmail.com. Thank you once again for joining me today.